dear audience. The title of my project, The Effects of Different Additional Therapies in Cerebral Palsy. My name is Márk Pulay, and I have graduated in the András Pető Faculty many years before, and I am a junior investigator in this project. My vision that Pető method contributes to better quality of life of patients with cerebral palsy, and my mission is to find and implement new cutting-edge technologies and additional therapies which fit to the holistical approach of the Pető method. To reach our vision, our mission, we set up 3 goals, 2 of this project investigating 2 different additional therapies. The first project is a systematic review and meta-analysis of one of these additional therapy called whole body vibration. But let me introduce a little bit cerebral palsy, which is co-used mostly by perinatal noxa and characterized by abnormal tone, posture, and movement, such as hemiplegia or tetraparesis. And we used to say that patients with cerebral palsy require lifelong therapies, such as physiotherapy or in Hungary, conductive education. Those are conventional therapies, and many additional therapies are available. And one of these promising treatments is the whole body vibration, and our aim is to evaluate the effects of this additional therapy on musculoskeletal system in patients with cerebral palsy. And here you can see a figure that this vibration platform can be used in different positions. Here you can see our PICO and the clinical question. P is patients with cerebral palsy, I is conventional therapy plus whole body vibration, C is conventional therapy with or without a placebo, and you can see that we have many secondary outcomes as well. We conducted a systematic search in the most frequent databases, and finally we got 17 eligible full text. Before I start to give you some preliminary results or forecasting some results for the implementation, it's important to know that the gold standard of the classification of cerebral palsy is the gross motor function classification system, which contains 5 different levels. The first level is the most independent, and the 5th is the less or dependent or more dependent level. Based on this classification, there is a measurement system. It's also widely used among these patients. It's the gross motor function measurement, which contains 5 different domains, and the scale is from 0 to 100. So the first forest plot gives you some picture about 2 domains. One of them is the standing domain, and the second one is the GMFM-E domain, which is the walking or standing, jumping and running domain. We didn't find statistically significant improvement, but I would like to highlight that this is an additional therapy, and even this is an additional therapy, we see positive and we find positive tendencies and clinically important changes. The second outcome is spasticity. Spasticity is one of the most significant symptoms in cerebral palsy, and this is why it's important to investigate this outcome. And as you can see, there is also a positive changing in or decreased muscle tone, which was measured with the ASFOR scale. There is a short description about this scale, which is actually validated, but nowadays there are more precise measurement techniques are available. So this is one of the suggestions that we should use such a precise methodology. Another result is the muscle strength, which is also very important in the intervention of patients with cerebral palsy. we also see this tendency. And if we should improve more RCTs into the analysis, it will be maybe statistically significant as well. To summarize the strengths of this project, that we include only RCTs, and we also find new results compared with the previous meta-analysis, such as spasticity or walking parameters. The limitations, as I already told, it's the different outcomes and measurement techniques. This is why we didn't involve many studies per measurements, and the age differences as well. Implication for practice that because of these promising effects on musculoskeletal system, we suggest to consider this additional therapy in the conventional rehabilitation programs. This is the progress of this project. And our second project is a pilot study. This is an other additional therapy called pulsed electromagnetic field therapy. Pilot study, but I used to say technical pilot, and I'm going to show you why is it more a technical pilot. This additional therapy, there is no RCTs on this patient population, but there are many convincing experience in disorders with abnormal muscle stones, so this is why we conduct this pilot study, and our aim is to assess the beneficial effects of this additional therapy symptoms associated with cerebral palsy. So it's a quite same PICO as in the meta-analysis. It was a single-centered pilot study. We involved children from 8 years to 12 years from the András Faculty Elementary School. And the primary outcome was changing or improvement in overall stability and muscle strength. Here you can see the inclusion and exclusion criteria. And the method we designed, as I told, a single-centered, randomized, double-blind, and placebo or sham-controlled clinical pilot trial. Here you can see the parameters of the intervention and the device, which is actually a pillow, and this pillow was placed on the lap of the participants, even in those conditions, so in the placebo or sham and in the intervention group as well. Finally, we involved 12 participants, and we measured the muscle strength with a hand grip measurement device. We didn't find significant differences. In the stabilometry, in one parameter, there was a significant changing in the control group, in the intervention group, but the number of the participants are really limited. But we can say that the technical outcomes of this pilot study have more clinical implication, or it's helping us to plan the third project. And the dosing is very important, that the intensity of the frequency that we used has no side effect, and we can say that we can use this intervention, or maybe we will increase the intensity and the frequency in the next measurements. Of course, there are some strengths and limitations as well. The strength is that this is the first pilot RCT, limitation as a number of participants, and implication for research that more RCTs are needed to specify the duration, intensity, and frequency of this therapy. This is the progress of this second project, and the third project is going to be a pre-study protocol of this after this pilot. So thank you for your attention. Between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. Thank you again, and if you have any question, feel free to ask.
I would like to ask something about your quote regarding your topic, because cerebral palsy, we know that has a lot to do with the perinatal noxa. So my question would be that do you think that if you actually use this from a perinatal ICU setting, for example in the incubators from a very early time, do you think this could improve the overall outcomes of cerebral palsy as the neuroplasticity decreases by the passing of time? So that's one clinically oriented question.
Thank you for the challenging question, actually, because it's of course somehow connected with my topic, but I'm not really familiar with perinatal intervention. But I think so, yes. So the question was that if we reduce the time or
if you use it early on. So from the beginning, when you suspect that there has been an injury that will lead to cerebral palsy symptoms on the long run, if you apply it from early on, do you think that it would significantly decrease the symptoms?
If we use this therapy, these additional therapies?
From the beginning?
Yes. No, I'm not really suggest that. So, sorry, I just understand your question right now. Okay, yes, because the main symptoms are developing later, so not in the very, very old young childhood. So it needs at least a few months or a year to see that the symptoms are coming. The first symptoms are mostly decreased muscle tone. So no, I'm not really suggest to use before 3 or 4 years old. Yes, thank you.
Is there any contraindication to using this therapy? Because in the older population, in adults, for example, sometimes vibration therapy is not recommended if there is any possibility of malignancy in the body, for example.
Yes, most of the RCTs set up some exclusion criteria for patients who are excluded from the intervention, such a patient with shunt, which is also very common among patients with cerebral palsy, or after some surgery, there is some contraindication, so indication after. Yeah, it depends on the surgery, what kind of surgery they have. But there are many exclusion criteria, yes.
Based on your results and based on your hypothesis, have you already changed your everyday practice as a conductor?
Actually, these devices are not very cheap, so it's one of the limitations that we have to find some sources to buy those devices. But there are some limitations, but I'm also, I have some short time or work in Austria, and we bought a vibration platform a few months before, so I have some experience as well.